what CMS meant by an isolating setting, or a setting that isolated HCBS beneficiaries from the larger communities. And in that guidance, we gave some specific descriptions to different types of settings that fell under the heading of intentional communities, be they farmsteads or any type of gated community where there was a combination of residential and day services, vocational services, and entertainment services, whatever, all in one location. And we said these are the types of settings that we meant when we said a setting that could be isolating. Well, we heard a lot of feedback, and it was not good. And so those providers took real issue with the fact that we were kind of painting them in an especially isolating light, and said it's really not fair for the government to kind of lump all of them together under this flag of being potentially isolating. So we did take that to heart, and for the past year, we've been working on revised guidance on those heightened scrutiny provisions. I should say that a setting that meets any of those three categories of being presumptively institutional, the state needs to take a special look at those settings and provide some documentation as to why that setting overcomes its institutional presumption and meets our reg, and then they need to submit that information to CMS, and we need to take a look at that as well. That CMS review of a specific setting is called heightened scrutiny, a heightened scrutiny review. And so there's a lot of providers who are really hopeful to avoid heightened scrutiny, and I'm not sure if that's where the energy should be. Heightened scrutiny is a pathway for us to say, the Royal Us, the state and CMS, to say, yes, you are on the grounds of an institution. Yes, you're inside an institution. Yes, you may have been isolating to individuals as you formerly provided services, but you do in fact meet the settings criteria, and you are a home and community-based provider, and your funding stream as such will be intact. So heightened scrutiny is not supposed to be a paperwork exercise for CMS just to delay a verdict of no, you are not home and community-based. It's really meant for the states and CMS to take a look at one setting as an individual setting and figure out how that location is providing services to individuals. We like to think we are going into this with an open mind. We have been receptive to the feedback that we heard from those providers who found themselves highlighted in a way they didn't appreciate in our earlier guidance. And so we have taken a crack at walking back from having specific examples of an isolating setting and having a more criteria-based conversation about what an isolating setting is in terms of how its way of providing services really infringes on an individual's ability to interact with the community. And if you are a setting that might see yourself still in that criteria of an isolating setting, there is time to make some changes to no longer be an isolating setting, and CMS is here to provide that kind of technical assistance. And so what we're really hoping to do is avoid disruption. We are not going to declare success if many providers cannot meet this criteria, and individuals receiving services need to find another provider, or individuals need to make some kind of wholesale change in the way they're living their lives in a way that does not create meaning for them. That is not the intention of this reg. It is meant to say we need to take a look at the way services are provided and make sure we are doing so in as person-centered of a way as possible. So we are not treating everyone with the same diagnosis or the same condition in the same way, recognizing the differences across individuals. But the need for CMS to be out and about talking with stakeholders is not going to end anytime soon, to try to combat misinformation, indicate what are federal decisions, what are state decisions. States have a lot of flexibility in this. A state can determine whether they want to continue doing business with a particular provider or a particular service model, and they could decide to use this regulation as a catalyst for some changes in their provider makeup. That's okay. CMS is not going to prevent the state from doing that. A state could decide that a setting that falls into a presumptively institutional category does not overcome that presumption and should not be submitted to CMS for a heightened scrutiny review, and that provider will no longer be a home and community-based provider. Doesn't mean that there's no other Medicaid category for them, but it means they won't be a home and community-based services provider. So, I would encourage you to understand your state's rationale and your state's vision for implementing the regulation. Find your state's statewide transition plan, ask questions of them, and then at the federal level, I'm certainly available to be the conduit into CMS and to the team that's engaged in working on this regulation at a national level, and I'm happy to open it up now for any questions. I've totally lost track of how much time I have for that Q&A session, so Susan, I'm going to rely on you for physical help. So thanks.
So we do have just a few minutes, unfortunately, for questions, because we had so much information presented there. It was wonderful. Allison.
Thank you. I really appreciate your presentation today. It was a lot of really good information. I want to express my appreciation for CMS's flexibility with regard to the intentional community rules. We're really looking forward to the new guidance and hope to see that new guidance quickly, particularly because we are facing a capacity issue, and that new guidance is really important for building new settings and giving people the new options for more options to live if that's what they choose to do. I wanted to talk a little bit about the transition plan, and specifically about the people who are involved and who are very much affected by these transition plans. I'm going to quote data from my own state of New York, just because that's where I live, but in New York, in our plan, New York has identified 72 settings that cannot be modified, which affects 6,900 beneficiaries, and 243 settings that fall under heightened scrutiny, and an additional 336 that could be. So my question is really, how is CMS prepared to ensure that those individuals receive their necessary benefits? Are you working with states to build new capacity so that there are ways for individuals who need these benefits to continue to receive them?
Yep, that's the question, or one of the main threshold questions associated with this regulation is we need to make sure at the end of the transition period that not only have we done all of this work to make the providers compliant with the regulation, but that we still have an array of providers designed to meet individuals who are at whatever part of their lives and whatever part of their diagnosis that they need the most supports for. And so, to continue using New York as an example, what we would do, and so New York is a state that has initial approval of their statewide transition plan, and that is relatively new. They received that in the last couple of months, I think. They do not have final approval. And so New York is one that has a whole lot of providers. One of the things that they needed to change was a requirement that, and I don't want to get too specific or I'll be wrong, but there was a particular type of provider that needed to be located inside of a nursing home. And so that right there is at cross purposes with figuring out what types of settings need heightened scrutiny if those settings are located inside a public or private institution. And so the numbers that they were giving us for the numbers of settings that might require heightened scrutiny were a little alarming because of some of the way their state statute is read, or state statute is written. And so we're working with them to try to figure out how best to crack that nut in terms of heightened scrutiny. And again, that would mean the state has made a determination that the setting falls into one of those three categories, a presumptively institutional setting, but nevertheless the setting overcomes that presumption, and then information will be sent to CMS. There could be, and it sounds like there is in these other 72 settings, a determination made by the state that the provider can't come into compliance with our reg by the end of the transition period, or the provider has communicated to the state they don't really have the intention to make changes necessary to come into compliance. And depending on the provider and the percentage of Medicaid funding in a particular setting, it might be that the provider doesn't find it financially viable for them to make any needed, or has a fear that it wouldn't be financially viable for them to make any remediations necessary to comply with the Medicaid requirement if a lot of their money isn't coming to them through Medicaid. And that's a very provider-specific articulation they would need to make. I don't know what's behind these 72 providers that the state has said can't make modifications. And so is it in the state's mind that those 72 providers will no longer be home and community-based providers after the transition period? Maybe. In which case the conversation would flip to, I should say that the regulation applies to services provided under three coverage categories in the Social Security Act. And that service is provided under the 1915C Home and Community-Based Waiver, the 1915I Home and Community-Based State Plan option, and the 1915K Community First Choice State Plan option. It's all alphabet soup. But it's services authorized under those three authorities that are required to be provided in a home and community-based setting. Other Medicaid services don't have that requirement to be provided in a home and community-based setting. And so there are other coverage authorities like the institutions, and then there are this middle ground of services that could be authorized under those home and community-based authorities, but they don't have to be. And so you've got home health services, personal care services, some private duty nursing services, rehab, which can authorize a lot of mental health, substance use services. My point being is that if a setting cannot meet the home and community-based services criteria and cannot receive funding under those three main HCBS coverage authorities, there could be other Medicaid authorities that don't require adherence to that regulation that would still authorize Medicaid funds. That again would be a very provider-specific conversation to figure out what services they're providing now. Is there a crosswalk of those services to non-HCBS coverage authorities? The answer could be yes, it could be no. If there will no longer be Medicaid funds at all coming into that setting after the transition period, what is the state and CMS collectively going to do about it? Could the state be picking up those services under state-only dollars? Maybe yes, maybe no. The strength of that maybe will depend on the state that we're talking about. And so there are a lot of downstream conversations that need to happen if there is doubt or certainty that a provider will be able to adhere to the regulation by the end of the transition period. And those are the conversations that, even though we still have 3 years left in the transition period, do need to be happening now. It's not in a, by what date in the next 6 months will we be making hard, fast decisions. At least some kind of process that needs to come into place to figure out at what point are we going to say, all right, a change needs to happen. At some point that is a plan and a process, but as time passes, that's going to get very specific to individual people and will certainly not be an academic conversation. It's impacting how people, from whom they are receiving services, perhaps where they live, how they live, and so we don't want that to be rushed as the transition period is winding down. And so that's why you'll see, as one of the required components for a statewide transition plan to receive final approval, the state needs to articulate a process for communicating with providers that have either already made a decision that they won't be in compliance by the end of the transition period, or the state is doubting that they will be. We don't want providers to be pulled prematurely and people to be either physically relocated or to find new providers earlier than they have to, but we also don't want, like I said, the waning days of the transition period to see a lot of decisions needing to be made in a hurry, which is never a good way to do things. So all of this is a long-winded way to say, what's happening in New York, I'm sure it's happening in other states, and it speaks to the need for states to take advantage of the full transition period and for the state and CMS to be in communication about what they're seeing as the transition period moves on. It really comes down to figuring out how many people are involved and what other options are going to be available to them. CMS most likely won't get into decisions that impact where a particular person moves. That's more a state and local decision, but we can walk through all of the potential options for maintaining federal Medicaid funding and then what options are available in the absence of Medicaid funding that could have some pretty direct implications for how conversations with individuals play out.
Thank you. There's a lot more questions and comments, but I'm afraid we're going to have to move on.
So I'll be here for the rest of the day, and I think my email address is probably somewhere associated with these materials. I'm happy to rattle it off now if you'd like to contact me as a follow-up.
If there is time in the schedule, we can return to this conversation later in the day, because I know there's lots of interest, but we have other speakers with time.
Let me quickly give you my email address, and then I'll stop, and then you can feel free to grab me throughout the day. It's Melissa, Melissa.Harris, Harris, at cms.hhs.gov.
Okay, thank you. Next on our agenda, we have a presentation from TRICARE, which of course is the military healthcare organization for active military. I welcome Captain Edwards, the Chief Clinical Officer of the TRICARE Health Plan at the Defense Health Agency and Department of Defense, and Christina Bienia, I hope I'm getting that close, Clinical Psychologist and Senior Policy Analyst at the Defense Health Agency. Thank you both for coming today, and we look forward to your presentation.
Great, thank you. My name is Chris Bienia. I'm a clinical psychologist, and I work at the Defense Health Agency, and I am the clinical lead for the autism benefit that we have under TRICARE.
Nice to be here. I'm Captain Ed Simmer. I'm a psychiatrist, and I'm the Chief Clinical Officer for the TRICARE Health Plan, which basically provides coverage for all of our military beneficiaries.
Okay, I'm not going to go through our agenda line by line, but essentially we're going to talk about the military healthcare system, the TRICARE benefit, how one gets medical services under this benefit, and then focus mostly on the history of ABA services under TRICARE, and then really our way forward. And hopefully, my apologies, we will glean information for everybody here in the audience.
Thanks, Chris. So I'm going to just give you a very brief introduction to what the military health system is, what we do, the kinds of things that we cover. So we are a worldwide system. Obviously, we have service members and their families in over 160 countries worldwide, and we have to ensure medical care in each of those locations. And we are focused both on health and readiness, very importantly. We have about 9.5 million people who rely on us for their medical care. That includes not only service members and their families, but also retirees and their families, because anyone who serves honorably for 20 years or is medically retired before that and their immediate family get medical benefits for the rest of their lives from us. So we have a lot of folks who are coming to our system at birth. They are born into a military family. They choose to join the military themselves. They then retire, and they may be with us from age 0 to age 100, and we're responsible for their care over that entire lifespan. We have both a direct and a purchase care system. We'll talk a little bit about that. Our direct care system is 55 hospitals right now and 373 clinics around the world. Those are facilities that we actually run ourselves and staff with military employees, some active duty like myself, also civilian employees and contractors. And then we also have a large purchase care system where we contract with civilian providers to provide care. About 70% of our care is provided through the contracts through the civilian providers, and about 30% in our direct care system. Obviously, the number one reason the military has a health system is to make sure that our military can go to war, can maintain the peace, do all the things that our military has to do. That's why there is a military health system. So we talk about two things that are really our vision. We need to, number one, have a medically ready force. That means that our troops are ready to deploy on a moment's notice and have all their medical needs met. Their vaccines are up to date, they're medically fit, they're ready to go and do what they need to do anywhere in the world on a moment's notice. But we also have to have a ready medical force, because we have to have medical folks that go with them to take care of them. So it's very important to us to maintain our medical forces so that they're ready to provide whatever treatment is needed. And certainly sometimes battlefield medicine is very different than typical civilian medicine. And so we have to make sure that we're keeping those skills up, and that's another very important part of our mission. You see that we have an enterprise approach. We are very much right now focused on moving the network care and the direct care, the care in our own hospitals, closer together. In the past, those benefits have been different. You could get different things in military hospitals than you could through our civilian program. We're trying to change that, and we're trying to make those rules the same. That's going to be a process, but we're certainly moving in that direction. We also, as you can see, our priorities and goals, I think the first two really apply to autism specifically. So we are looking to optimize our operations, become as efficient as possible, but also very much focused on moving towards a high-value system of care so that we're providing high-value care that's proven effective, and minimizing the use of low-value care. So if I can give you a medical example, we want to encourage the use of vaccines so we don't have to treat as much illness from folks who aren't vaccinated. So that's an example of high-value versus lower-value care. And of course, we want to create outcomes for health, well-being, and readiness, because we realize that family readiness, which really what we're going to be talking about here today with our autism care, very much impacts on service member readiness. I'm a psychiatrist, as I mentioned. When I've been deployed, I've seen any number of soldiers or sailors come to me, and one of their primary concerns and reasons that brought them to me was they were worried about the health of their family back home. So when we take care of the family, we're actually making the service member more ready too. I think we have one of the most generous medical benefits of anywhere in the world. If you are an active duty family member in our HMO program, there's basically no cost to you for any medical care. Your prescriptions are free, all of your medical care is free. Basically, you get everything at no cost. There's no co-pays, no cost shares, no deductibles. Even for our retirees, the catastrophic cap right now is $3,000. So even if you need $1 million worth of care, you'll never pay more than $3,000 in a year. So it's a very generous benefit. As I mentioned, we support 9.5 million beneficiaries. We are not health insurance. I think that's a very important distinction. We are an earned benefit. People deserve this benefit because of the service they provide to their country, and I think that's an important distinction. And we are governed by law, and Congress does from time to time and has with the Autism Care Program. Can get very much into the weeds and tell us exactly how they want us to administer the program. So we do have some statutory requirements that tell us how to do this. And you'll notice that because we have a lot of young active duty members, we have a lot of children. So about 2 million of our beneficiaries are actually under the age of 21. We have the basic benefit. The basic benefit is what we cover for everyone. Unlike most civilian insurances, you can't buy different types of TRICARE. You can be in TRICARE Prime, which is the HMO, or TRICARE Select, which is more of a preferred provider network. But other than that, everybody gets the same benefit. Everybody gets the same coverage. The same things are covered. The same cost shares and that apply to the retirees. There's one level of benefit in our program. So that's kind of a difference from most civilian insurance. We cover all medically or psychologically necessary treatments, and we'll talk about what those criteria are, how we determine that. You can see the definition there in the law, but let me move on because I think it's important to look at both. Let's talk about what's covered under this definition and how we got to that point. So we cover medically necessary evidence-based treatment, and we'll talk on the next slide about how we determine what is evidence-based. But for children, and actually we do have some adults too in the Autism Care Program, they can get OT, PT, speech and language therapy. All these are evidence-based for autism. Obviously primary care, of course. In the HMO system, the primary care manager actually manages all that care. And then we certainly have robust mental health benefit. In fact, we just expanded that significantly. And as I mentioned, all medications, prescription medications are covered, usually without a copay, especially if you're getting them through a military treatment facility. We also, for active duty family members only, one of the challenges for active duty families is Medicaid waiver programs. And a lot of children with autism utilize those. A lot of our families, they move every 2 to 3 years. That's the nature of military service. So by the time they get to the top of one of these Medicaid waiver waiting lists, it's time to move again. They move to another state, and guess what? They go back to the bottom of the list. So they can never access the Medicaid waiver services that they're entitled to because of the way the waiting lists are. So we have what's called the extended care health option, which provides specific benefits only to active duty family members because they're the ones moving around a lot. And that does provide some additional benefits to children with autism, respite care being one. But there's also other things you can get through that program, such as modifications to a vehicle, so you can get a wheelchair lift, translation services. There's a number of things you can get through that program that's specific for active duty family members, and a number of our children with autism do use those services. So let's talk about how we determine is something a covered benefit. Are we going to cover something for a child with autism specific to this audience? So you can see there, it's actually governed by federal regulation how we determine what's a benefit. And these are in order of importance, and we actually have a whole team out in Aurora, Colorado that does nothing but look at the new research, monitors the journals, and reviews all sorts of different treatments and things to determine what should we be adding to the benefit. And on rare occasions, even what should we take out of the benefit. The research shows that something we thought worked actually doesn't. So number one thing is well-controlled studies with clinically meaningful endpoints. We are looking for that to be in a peer-reviewed journal. We prefer controlled and blinded studies when possible. But we also realize, especially in the pediatric population, that you're not always going to get a lot of that because there are both ethical and practical reasons why that kind of study can be difficult in the pediatric population. So especially in pediatrics, we tend to rely on the other 4 things you see there on the list as well. I'm not going to read through them all, but basically what we are looking for is things that are well-grounded in evidence. It has to be well-done research. All the other things there have to be research-based. So if we're looking at a technology assessment, a report of a National Professional Medical Association, if it's just somebody's opinion, we're not going to give a lot of weight to that. But if that is a well-documented report from a professional association, they say this is what we recommend and this is why, so it's like a clinical practice guideline, we're definitely going to consider that in our deliberations. If this standard is met, that becomes a covered benefit, and all the beneficiaries are eligible to receive it if they have whatever diagnosis is appropriate. So let's talk about how we determine what is and is not a covered benefit for autism. Because you'll notice on that list that I showed you with the OT, the PT, and all that, applied behavior analysis is not on that list. Applied behavior analysis, which is commonly used for autism, is not part of our basic benefit because it does not meet our hierarchy of evidence standards. The evidence is not strong enough to support use. And we actually did a very extensive literature review, as you can see here. We have